Welcome to Senior Speak New Hampshire. I'm Dan Wise, a volunteer for AARP, which sponsors this show. It's October. October brings many things: pumpkin spice, falling leaves, chilly nights, and Medicare commercials. October is the start of the open enrollment period for Medicare from October 15 to December 7th. And new enrollees or others can sign up for Medicare or choose a Medicare Advantage plan. Last year, according to Kaiser Health News, more than 85% of the commercials, or 9,500 ads per day, were for Medicare Advantage, the private plans that now enroll more than 50% of all eligible people for Medicare. These ads rarely mention that traditional Medicare is available. They don't talk about the potential limitations of Medicare Advantage, such as provider networks that limit who you can see, or prior authorization requirements that might deny coverage that you want to have. So we're going to talk today about some of the lesser known, less attractive facts about Medicare Advantage. To help me, my guest today is Ken Dahlkert. He's a board-certified geriatrician, a physician with more than 41 years of experience. He practices, teaches, and consults at Geisel Medical School in Lebanon. And I want to thank him for coming down here and talking with us. Ken is also a student of the history of health insurance in this country, so he's a very informed guide. So thank you, Ken, for coming on.
My pleasure.
Coming on. First, let's talk a little bit about the differences between traditional Medicare, which is provided through the government, and Medicare Advantage. Can you? You're better
Sure.
at this than I am at sort of explaining that.
Absolutely. So, the origins of Medicare in 1965 was that you could not find an insurer who was able to cover seniors with their increased costs, their increased hospitalizations, and their increased medical needs. So at that juncture, the government needed to step in to cover seniors. Original Medicare or traditional Medicare was set up as a very simple plan, highly efficient. The administrative overhead is 3% because it's basically managed by one entity, which is the government, and it had one program to cover those over 65. The flaws that were built into it were kind of interesting in the negotiations of getting the Great Society passed and Medicare passed. The AMA insisted that physicians and hospitals could set the rate, could set the prices for medical services. The Medicare program realized very quickly that was going to be a problem, so they instituted some restraints on that have been built into traditional Medicare since then. With time, Medicare started to cover dialysis patients, patients with disabilities, but it was also recognized that other needs that seniors were having from the simple 1960s included drug coverage. We were on a lot of expensive drugs in the 1960s. This became really an issue in the 1980s with other legislation that was passed. And clearly there was a great need to have seniors have their drug coverage provided. The other issues were recognized of need for dental care, for hearing and vision services. These additional benefits could have been added to the Medicare program with its maturity and as things changed. However, the world changed a little bit. 2003, the Medicare Modernization Act was passed under the Bush administration, but more interestingly, it was written by the pharmaceutical industry and the medical insurance industry. Basically, a lot of the legislation was from those lobbyists. And they instituted Medicare Part D, which was a needed coverage program for seniors, but via very specific methods, such as pharmacy benefit managers, and also opened the door to make Medicare, privatization of Medicare more profitable. Which, yeah.
Was it also a matter that with expanding the coverage of those other things would have cost more money, and so the private industry stepped in to say, hey, it won't cost the government so much money if we privatize.
Sure.
Is that sort of
Very
what
interesting.
happened there?
Yeah.
Okay.
So the smartest guys in the room from the industry said, oh, we can offer managed care. So we can actually do two things simultaneously, which seem to be at odds with one another. We can reduce costs and expand benefits. Terrific. Could they do this? No, they couldn't. And in fact, the experience has been just the opposite. How did they say, what did they purport to put forward as the method to do this? Well, they said there are innovations in the private industry that government couldn't do. Not, in fact, true, but some of those innovations, which are actually geared towards profit, include limiting networks. So traditional Medicare, you're able to see any physician who takes Medicare, which is 99% of adult physicians in the country, and go from California to New York and Florida and back and see any physician you like in those areas. The physician who's making medical judgments about what tests you need, for the most part, never need to encounter prior authorizations. It's rare. There's rare tests that might be the case, but there's no restraints, which Medicare Advantage said, look, we can use narrow networks and make sure that these are, and they make contracts. So Medicare Advantage is a middleman. They are capitated by Medicare per patient per month to provide Part A, Part B, and Part D. So the drug coverage. The drug coverage, the hospitalization, which is Part A, and all the outpatient services. And in doing so, they contract with hospitals and private practices. A lot of hospitals are dropping their Medicare Advantage plans because they are not able to essentially negotiate to maintain good care for their patients. They're not making enough money. It's also true in health agencies that work in the community. But in any case, that was one of their purported innovations.
Narrowing the
network.
So,
and the other technique that they were counting on is prior authorizations, that they were going to limit the unnecessary care, which in reality is not enough to expand benefits. So,
and this is all supposedly addressing some of the earlier flaws of uncontrolled, sort of unregulated.
No question. I mean,
that were out there.
Nihilism and the government can't really perform it. Even though the experience of seniors has been terrific with Medicare as a simple, efficient, well-administered program. So let's
go to what the choice is right now. So we have a couple slides that kind of go through the way these features have come out of this evolution of lobbying and practice in reality. So there's a pros and cons slide that we can show, and it shows that so traditional Medicare, you can see any doctor that accepts Medicare, which is most, and there's some traditional co-pays and things like that, sort of like traditional private insurance. There's no referrals. You can go to any doctor you want. So if you want a second opinion, you can get a second opinion from another doctor. You can, if you think there's a specialist in some other place that you can go to, you can do that. And it's only, there's Medicare A and B, and it's basically you're covering hospital and physician services.
And Medicare Part B covers 80% of outpatient services. So the physical therapy, the chemotherapy, so the rest is actually for those who can swing it, which is many Americans, is what's called Medigap, which was this creation back from traditional Medicare that covers the 20% that Medicare Part B does not cover. And there's typically a modest deductible with that. And as you were saying, if you have a particular unique complex medical problem, you can choose the hospital you wish to go to. That's an important point for many people who have various issues, whether it be heart disease or cancer or a variety of other complex issues.
I was at the point of deciding between Medicare, and I used to be kind of a big fan of of HMOs as something that was controlling care and costing a little less and was more efficient and all that. But then when I was looking at that, my a relative, her husband had cancer, and he was recommended to go to someone else who recommended a different therapy. And I just realized it's like, well, right now I don't have any special medical needs, but if I did, I'd want to be able to go where I'd be best served.
Sure.
And Medicare plus a Medigap supplement plan, which means you've got to pay out of pocket every month. You have a premium that you more on top of the Medicare premium. You have another premium you have to pay to a private insurance company for a Medicare supplement plan. But it's not. But if you sign up for it at the very beginning, they will accept anybody, and it will be what they call community rated, which means that you are paying. I'm not sure how you describe it, but you're paying a population average rate. You're not being subjected to a medical exam that will raise your rate based on your pre-existing conditions. It takes anybody at that. But the key is that you have to sign up for that at the beginning in order to not have that kind of
absolutely, and it's an important
underwriting.
It's an important point. I mean, I do have patients who are happy. They have very few medical problems, if none. They may take no medications. Of course, you get insurance because you are uncertain about what life will befall on you, and there's an inevitable aging process that does result in illness as we get older. But for folks who are young and healthy and active, there are some advantages. It's bundling Medicare, the various parts of it. Premiums are very, very low, if not non-existent.
Yeah.
They do this in a variety of different ways, which we may not have time today to talk about in terms of how they get reimbursed and capitated. But in any case, the problem becomes, for many seniors, once you start to have medical illness, and you need a heart valve replacement or bypass, or you need cancer chemotherapy or the like, you're finding that all of a sudden you're getting co-insurances for the chemotherapy, co-pays for your home therapy. You may go to a skilled nursing facility and they'll say, no, we're not going to cover that. You're out of luck. Or you can go to this skilled nursing facility, which is farther from home, rather than this one.
Yeah, we'll get into that in a minute.
Yeah.
I want to get more into kind of what your experience has been in terms of patients, but just clarifying what Medicare Advantage, which is, what is it, Part C?
Part C, yes,
They
indeed.
sort of say Part C as if it's part of Medicare when it really is supplied by a private company acting as a middleman, which gets money per patient or per covered person from the government.
Right.
But sometimes in some places Medicare Advantage is free in terms of not having premiums, and they offer vision and hearing and maybe even some dental coverage. However, and then there is some sort of a cap, I think, on out-of-pocket expenses.
Yes.
Which I've never quite understood how that works.
It's really
because what I've also heard is that if you get sick, Medicare Advantage, suddenly you can find that it isn't covering all the things that you need.
Sure.
And so this is something that I think you particularly are
Yes.
well positioned to talk about as a physician who works with older folks.
You're bringing up important points. Traditional Medicare does not have a cap on out-of-pocket expenses. It has no co-insurances. Your physical therapy does not require a copay. There's a lot of other things that are covered. And if you have Medigap, you usually do okay in the setting of medical illness. When they privatized with Part C, as you're saying, Medicare Advantage, there is a cap. Typically $8,500 for commercial programs throughout the country. That's federal legislation. The problem, so there's a low entrance fee. There's no premiums to get onto Medicare Part C to get onto Medicare Advantage. Folks love the fact that it's relatively inexpensive and bundled. Once there are medical illnesses, however, you meet that cap of $8,500. through the co-insurance and a variety of other issues. And if you are in a managed care organization that is basically serving with narrow networks, if you're going to be totally responsible for all the care if you go out of that network to another hospital. There are PPOs, so the state of New Hampshire offers a Blue Cross Blue Shield Anthem PPO, which sort of by its
Which is
plan.
It's a wider
scope
network.
Exactly
but it's
right.
Still, you're still kind of contained as to who you can see.
Exactly right.
Yeah.
So it's interesting. There are many studies now that have come out in the past couple of years that demonstrate, yes, folks who are perfectly well do better financially with less out-of-pocket costs. Once you start having medical expenditures and medical needs, it's actually a wash, and oftentimes it's more expensive, despite the cap.
Yeah, there's a slide we have, the low entry fees, high maintenance fees slide,
Sure.
which kind of goes through that. It's like Medicare Advantage, at first blush, you don't have very many medications, you're in good health. You don't particularly, since you don't have any serious medical issues, you might not have any really strong preferences about who to go to for a doctor. You may not even care that, the doctor, you don't really, see them very often. So convenience is not really an issue to you.
Sure.
And you kind of like the bennies. There are a lot of bennies that benefits that get advertised. They're going to help you with a fitness plan, and you're going to get a dental plan and vision and prescription drugs. And an article that you sent me talked about how it turns out that some of these things, like the dental plans and the vision plans, ultimately don't really benefit people a lot. Like if you really need a lot of dental work, the dental plan doesn't really pay all that much more. And sometimes these folks find that they don't even really use those things all that much. So it's sort of a little bit, since we're in October, it's a little bit like trick or treat. And you think that Medicare Advantage giving all this for free is a treat, but there's really a couple of tricks involved. So let's talk. So you were saying earlier that and if you have a serious condition, you might not be able to go to the doctor you want, and then there's treatment options that might not be available to you.
Yeah, and expenditures add up. If you want to get a second opinion for your cancer and you go to an out-of-network physician, that's going to be right out of your pocket. If the other issues which do arise, and I've seen, is if your chemotherapy, if the oncologist, the cancer specialist, wants to give you what they feel is now the best agent, but also happens to be expensive, the insurer, again, they're in it for the profit. I mean, they're traded on Wall Street. This is their mission statement, which I understand. But they will say you have to do step therapy. No, we won't give that agent unless you go through this agent and fail treatment with this other therapy, or similar kinds of formulary restrictions. So it does impact on medical decision making by one's clinician. I think that, again, if you're healthy, there's benefits to be had. The problem is, as we get along in age, if you're on as you were alluding to earlier, if you're on Medicare Advantage for more than a year, when you leave Medicare Advantage, because I don't like
trick.
One of the tricks, trick or treat. I don't like my Medicare Advantage anymore. I'm paying too much for this. I can't see the doc who is recommended to me for this particular condition. Great. I'll just switch to Medigap. I'll go back to what I had. After a year, in all but 4 states, it's going to be very difficult to do that because you no longer have guaranteed issue. What that means, I'm on Medicare Advantage. It's been a year. I want to switch. Now, the Medigap coverage insurers no longer will do community rating, giving you this large pool of healthy and unwell folks, everybody in Medicare, which includes a lot of healthy people. That brings down costs. Now, that Medigap plan will say, hey, I'm going to price your premium based on your pre-existing conditions, on what you've already been through, which may be why I'm trying to leave Medicare Advantage.
Which may be what, yes.
And so they're going to raise the rates so that it's profitable for them, but it's typically unaffordable for the person.
They could even deny you, isn't that true?
and is often the case.
Yeah.
They just don't even bother. They said, I'm not going to underwrite you because you have cancer or you had, active vascular disease or Alzheimer's, or whatever the issue might be. So I have heard this from a number of patients and a number of people, seniors I talk with, that they're stuck. They feel they're trapped. They can't get out of Medicare Advantage once they start to incur these costs. There are 4 states, by the way, in the union. Maine, next door, which I have friends in Maine who are very happy to have that option. Massachusetts, Connecticut, and what am I missing? Anyhow, Connecticut, Massachusetts, Maine, and
It's not Vermont. It's Connecticut, Maine, Maine, Massachusetts.
there's one more state.
Rhode Island?
Rhode Island, I think it is.
Okay.
And it's a very simple fix. And if you look at the statutes in the New Hampshire State House that have been written, you can make a very easy fix to allow guaranteed issue and community rating. Oh, New York, not Rhode Island, New York.
Okay.
That's the other, not New England. So they have that experience with that. And that would actually help level the playing field for folks who wish to leave Medicare Advantage and get back to a Medigap plan, or vice versa.
Yeah. So one of the other things, though, is that looking at Medicare Advantage from the taxpayer's point of view, there's a whole other aspect of this, that aside from being the decision you make as an individual, it's good to understand what's happened with the private insurance industry's advocacy or manipulation or whatever of the program of Medicare Advantage, which was designed, which was promised initially to be a saver of money per beneficiary for Medicare. It's like, oh, we're going to be efficient. We're going to do all these efficient things. But now it's turned around, and the insurance companies get paid more for the beneficiaries than what traditional Medicare ends up paying for the rest of us. And
Sure.
Can you? And now this is a little complicated.
I'll try to
not dip too
sure.
far into it, but there's a couple of reasons why
Sure.
this situation exists. Can you?
Absolutely, Dan. And I
go
think
into that?
it's really unbelievable how much the Medicare Trust Fund is hemorrhaging money because of overpayments. The Congressional Budget Office, this is not an estimate from a private or think tank. This is our own CBO. Estimated that in 2023, Medicare Advantage was overpaid $88 billion. That's $88 billion.
Billion with a B.
We talk about, the savings with the Inflation Reduction Act. That's $6 billion on negotiating with Medicare. That's repealing the Part D plan from that's extraordinary amount of money. They're predicting about $83 billion in 2024. Why is that happening? Well, with time, the legislation was designed to have a certain function of creating contracts between the private industry and Medicare. And a Medicare Advantage plan will be capitated based on a benchmark that exists among that pool of people, the cost of taking care of a pool of people in traditional Medicare. So if you're in traditional Medicare, some people are very sick, maybe need a bone marrow transplant. Many people are completely well. So the average cost is what we'd call community rating. If you look at traditional Medicare in a particular area, which is how this is created, that benchmark is then compared to what the plan will offer for their to get paid for in their contract. The interesting thing is Medicare Advantage puts out the bells and whistles and is able to do cherry picking and encourage lemon dropping with some of the techniques we've talked about, such that their pool of people is actually significantly healthier. So even though the benchmark is here, the folks that they're bringing into Medicare Advantage actually have lesser costs. So you're starting off with a healthier population, but you're getting paid more for them. Plus, so that's part of this whole issue about favorable selection. Okay. And Congress has been looking at this, and boy, it's an ongoing issue. There's other aspects that go into this capitation process. The defense industry comes to mind. Whoever would think that there'd be defense industry problems in the world of Medicare? Remember the $600 hammer? People are talking about the abuses in the defense industry. Oh, nobody's really minding the store, and you're making these ridiculous. That's happening in your Medicare that you're having your specific FICA taxes go to. Now, the good thing about the defense industry is at least they make jets. You could fly them. You could see them. You could hear the Mach 2s breaking the sound barrier. The insurance industries are making insurance policies. And they might fly if you make them into a paper airplane, I suppose. But it's extraordinary the amount of overpayment that's going to the Medicare Advantage plans. Based on this, we may have touched on fraud. I'm not sure we talked about upcoding and fraud.
No, we didn't mention that. So you start out with that standard per patient fee that the Medicare Advantage plans are getting, and because of all the marketing and all those wonderful commercials and the fact that they're offering a health club, health benefits and things like that, they're getting this healthier population. So they're already making money. But that's not it. But that's not all.
Right.
They're making money in a different way.
So it's interesting.
It's a little bit shadier.
We're in the wild west of basically the health insurance industries and private equity and 1,000 other things that would blow most listeners' minds. But be that as it may, in terms of what's happening in the insurance industry with Medicare Advantage and upcoding. So if a person has a particular medical condition, they have hypertension, you'll get reimbursed if that hypertension is malignant hypertension or accelerated hypertension. If you get dehydrated because you're working too hard on a summer day, you didn't drink enough fluid, and you happen to go to the emergency room and you're getting faint, yes, your kidney function will be impaired, but really you're dehydrated. But you could say that that's acute kidney injury because they'll upcode.
The insurance company will comb through. Will use Will use our premium dollars to carefully and precisely investigate how to make each patient look less healthy.
Absolutely.
And they get a special increase.
They'll increase their risk of their percentages. They'll be able to get reimbursed more based on this is how ill our patients are. And if you ever wondered, if you have Medicare Advantage, why they're pushing so hard for that nurse to visit you, when you first enroll, you'll have a nurse practitioner. They're really pushing you hard by telephone. We'd like to get this person out there to meet with you, to do preventative health, to do your wellness exam, all of which is great. I'm a big believer in preventative health. The reason it's profitable, though, and the reason they're encouraging and they're incenting this is because they will then look at every diagnosis you've ever had and actually upcode it. So that, and by the way, in many instances, studies have shown that's the last time you'll see a visiting nurse. It's for the initial, it's very interesting. That's one issue, which is manipulating these risk scores based on upcoding and diagnosis. And in fact, the Medicare Advantage plans get 6% more per enrollee. That's per enrollee than the cost for the same enrollee if they were in traditional Medicare. However, they pay 25% less in care. They provide 25% less in care.
You're ending up getting less.
They make something like, they make $1,730 of profit, which in the insurance industry is apparently a fair amount the other problem as a taxpayer is outright fraud. So there's upcoding, which is, sort of gray zone of fraud. The Wall Street Journal had an article that the insurance company, and as did the New York Times, were billing for diagnoses patients didn't have, for HIV that they were never diagnosed with or other disorders. So there is a lot of stuff going on in this industry that we've seen with the HMO experience of the 1990s and the employee-sponsored industries, insurances. It's problematic, and we're hemorrhaging
a lot of money that's going out that way.
Yes.
So, and then earlier we talked about the idea that there's been a lot of ways in which Medicare Advantage, the insurance companies offering Medicare Advantage, have sort of an uneven playing field in terms of competition with
Yeah.
traditional Medicare, which isn't advertising on TV and doesn't have these bells and whistles. Now, what are some, to wrap up, kind of, what are some of the ways that the government could,
Sure.
or Congress could make traditional Medicare better?
Yeah,
Is
for
that
sure.
an option?
It's clearly an option, and it's extraordinary that it wasn't the path that we took back in 2003. So, by the way, one of the simplest things you could do is that $88 billion, and by the way, there are estimates, if you add fraud, it's up to 120 to 140 billion. That's a lot of money. That would actually pay for the coverage of every senior who's in Medicare's Part B premium. So you still pay Part B premiums, by the way, if you're on Medicare Advantage.
Right.
It's like $180 a month or whatever it might be. That would cover every senior in America's Part B premiums. That's one thing that you could do with $88 billion. You can cover dental care, plus hearing and vision.
Wow. Which is, if you're old, you know, it's like when I first got Medicare, it's like, you don't cover vision and hearing? It's like,
Right.
that's what affects older people.
The mouth is part of the body. It's extraordinary.
And dental, yes.
Yeah. So all the above, vision and vision actually and hearing are not expensive. And that's only getting, particularly hearing is with newer technologies becoming very affordable. So Medicare could easily be on that level playing field to compete with Medicare Advantage. As a single, essentially, Medicare runs the show. They could decide what they want to expend on the cost for these things. They have that power. They decided to give away the power to the private industry, which has given away a lot of our tax dollars. So again, in terms of pharmaceuticals, people are pretty tuned into what's happened in that industry and the necessity to rein in the exorbitant prices. So that will also happen in Medicare. Will finally, when Medicare Part D was written, as people might know, it was prohibited from negotiating with drug makers. That's been repealed under the Inflation Reduction Act, but that's just one little other iota of how Medicare can be made more cost effective as it expands benefits. So, yeah.
And I think the other thing that we have some resources that I want, and there's a slide that has some resources that you can look to. And I want you to note that these are, the SHIP program is impartial folks who will help you sort through the incredibly complicated options that exist. For example, Medigap, the supplements to traditional Medicare, there are a number of choices, and it's a little complicated, but the SHIP will help you with that. Medicare.gov is the actual government Medicare website. There's many other websites that you may come across that are advertised that will call you on the phone, or that you'll see on TV, that call themselves the Medicare Help Center, the Medicare Central, or whatever. Usually they are .com because they are actually commercial insurance brokers. And going back to the beginning when we talked about all of the advertising that you see, it's incredibly, as you found out, it's incredibly profitable for these insurance companies to offer Medicare Advantage because of all the goodies they get from our FICA money. The other thing is that brokers, there are a lot of insurance brokers will come up with these names to sell Medicare Advantage because they get very healthy commissions from Medicare Advantage plans. So it's a little bit of a daunting world, but the resources that we indicate there, Medicare.gov and the SHIP program, I think if you call I think it's called the helpline.
For SHIP?
Yeah,
Yes.
for SHIP, you can get ServiceLink. ServiceLink in New Hampshire helps older folks with a lot of different issues, and they can direct you to the SHIP program in New Hampshire, or to for Medicare and for other programs. And so You can also look for, maybe an impartial source like Consumer Reports talks about Medicare Advantage. AARP does also have some resources for Medicare Advantage and Medicare choices in general. However, I do want to point out that AARP has a marketing relationship with one of the offers of Medicare Advantage or Medicare supplements. And it's important to distinguish that AARP is not an insurance company. They have an advertising relationship with United Healthcare. And, but there is good information on the AARP website, but make sure that it's aarp.org and not the United Healthcare, which is one of the players in this whole thing. But you do have to be careful out there, but I do want to encourage people to understand the differences between traditional Medicare and Medicare Advantage, because there are some tricks among the treats. Well, thank you, Dr. Dahlkirch, for coming, and thank you for listening, and I'll see you next month.